Muy buenos días a todos a esta reunión especial de la Asociación Chilena de Hepatología en la que contamos con un destacadísimo expositor. Estoy aquí con el doctor Fernando Gómez de nuestra asociación y vamos a moderar esta sesión que hoy día va a tratar de colangitis esclerosante primaria. Voy a cambiar al inglés para presentar a nuestro expositor y proceder con la presentación y después tendremos posibilidad de algunas preguntas al final de la presentación. Va a haber traducción, así que ustedes se conectan al canal que más les convenga. Doctor Gómez, muy buenos días.
Buenos
Dr.
días.
Troner, Dr. Troner, it's a real pleasure to have you here, presenting in our National Hepatology Association monthly meeting. This is a special time because we usually do this in the evenings, but that is going to be complicated for you, of course. So again, thanks for here, and I will present you to the audience. Dr. Troner is one of the most renowned hepatologists in Europe, and I had the fortune to be his friend and know him from almost 30 years. We were at some point together in our training in the US. And he has devoted these last 30 years plus his training to the study of biliary diseases, including cholestasis, primary biliary cholangitis, and primary sclerosing cholangitis, which is the topic of today's talk. And he has an really impressive curriculum with more than 500 publications and an age index of over 150. So he is really one of the leaders of the field, and we are fortunate to have him here to talk about primary sclerosing cholangitis, a topic in which he has been involved deeply, both in basic science, pathogenesis of disease, and also treatment with development of new agents to treat the disease. So with that short introduction, because we could speak a lot about his trajectory in academia, I again give a warm welcome to Michael. And again, thank you for being here. And we really will enjoy your presentation.
Yeah, dear Marco, dear Dr. Gomez, dear colleagues and friends, thank you very much for the kind introduction. I'm really honored to speak to you at this early morning hour for you. Thank you very much for getting up. And as Marco alluded to, we really share this passion in trying to understand cholestatic liver diseases, mainly, primary sclerosing cholangitis, which many refer to as the last box, one of the last boxes in hepatology. But despite being still a mystery disease, there's a lot of progress going on, and I hope I can share some of the novel insights with you this morning. So please, Marco, if you advance the slide. So for technical reason, we are sharing the PDF. These are my faculty disclosures. Let's move to the next slide. So these are the key points which I want to touch upon today in my presentation. First of all, the challenges of making a firm diagnosis of PSC, which often is not that easy, giving the complexity of the differential diagnosis, considering also the wide spectrum of secondary sclerosing cholangitis. Then I want to highlight liver transplantation being the only curative treatment for this disease, also reflecting limited therapeutic medical options at the moment. However, there's a high risk of recurrence, so there's a major burden coming from liver transplantation for PSC, despite being a very rare disease. Then I want to highlight the risk of malignancy in PSC, which accounts for nearly half of death in this disease. And finally, review the evolving therapeutic landscape. So let's move on to the next slide, please. This is a summary of where we stand in PSC at the moment. So in contrast to PBC, primary biliary cholangitis, where we have an established first-line treatment with URSO and already second-line therapeutic options with FXR and PIPA ligands, in primary sclerosing cholangitis, there is no established drug treatment. In many countries, the use of URSO is still controversial. For example, Nordic countries such as Norway don't even use URSO in PSC, despite the high prevalence. There's the association with IBD in 70% of cases, We often refer to IBD and PSC as the third phenotype, having this right-sided, right dominant location with backwash ileitis and also rectal sparing, which may explain why much of very often the colitis in PSC is quite oligo or even asymptomatic and frequently overlooked before the diagnosis of PSC is finally made. And then we have the very high risk of malignancy, not only cholangiocellular carcinoma, but also gallbladder cancer and also colorectal cancer. In addition, when patients have progressed to cirrhosis, there's also the risk of hepatocellular cancer. So let's move to the next slide, please. This slide is summarizing the clinical features of PSC. So the typical patient would be a 30 to 40-year-old male presenting with IBD and abnormal alkaline phosphatase. The diagnosis is made by MR cholangiography. There's also a small fraction in about 5% of cases which only presents as small duct PSC, which however may progress to large duct PSC in about 25% of cases over 8 to 10 years. And the diagnosis of small duct PSC requires liver histology because in these cases, the cholangiography still is normal. We have the association with IBD, so it's always important to perform an index colonoscopy irrespective of symptoms in these patients. The atypical P anchor don't really have a diagnostic value, but recent data from Norway actually show that their presence may correlate with the worst disease outcome. So they may have a certain prognostic value. Let's move to the next slide, please. So this slide is summarizing the clinical heterogeneity of PSC. We all are aware that it's a mixed bag. We have patients which take a more favorable course, actually absence of IBD and small duct PSC, or younger age of diagnosis, female sex, and interestingly, actually overlap with autoimmune hepatitis has a more favorable diagnosis, whereas extensive biliary involvement, mainly involvement of both the extra and intrahepatic biliary tree, the presence of dominant strictures, elevated IgG4, which can be elevated in PSC, making the differential diagnosis to IgG4-related cholangitis a little bit challenging, as well as African American and Hispanic ethnicities having a worse outcome, probably also due to delayed diagnosis. So it's a very mixed bag, and it's actually a challenge to really predict the prognosis in the individual patients, and we'll go into that in a little bit more detail. So let's move to the next slide, please. This slide is highlighting the importance of really always excluding secondary causes of cholangitis. And these secondary causes is really a mixed bag, a sushi box of different differential diagnoses. It's important to make always exclude secondary causes because these are potentially treatable causes such as IgG4-related disease, which often involves also the pancreas in response to steroids or immunosuppressive or B-cell depleting agents such as rituximab. There are newer examples of secondary sclerosing cholangitis, also with checkpoint inhibitors. We are seeing these cases. Ketamine has been linked to the occurrence of secondary sclerosing cholangitis, mainly during the COVID pandemic, which also brought up many ICU-related ischemic cases of secondary sclerosing cholangitis. And the next slide is actually summarizing the differential diagnosis. It's always important to exclude chronic biliary obstruction, infections, both viral or parasitic infections or other immunological diseases such as IgG4-related disease, but also eosinophilic cholangitis or rare cases of mastocytosis, which we sometimes encounter, can give rise to the picture of secondary sclerosing cholangitis. And then in addition to ischemic cholangiopathy, which is basically what happens in the ICU setting, including COVID, where we saw an alarming increase in the prevalence of secondary sclerosing cholangitis, it's also important to exclude genetic cases, mainly ABCB4 mutations of the phospholipid export pump. And the next slide is summarizing the diagnostic algorithm which we usually follow when we work up unclear cholestasis, or first after history and an ultrasound to exclude biliary obstruction, we would perform PBC-specific autoantibodies to make or exclude the diagnosis of PBC. Then comes MRCP, where we would make the diagnosis of sclerosing cholangitis. And then liver biopsy, for example, allowing the diagnosis of small duct PSC. And at the very end of this suggested algorithm comes genetics. And actually, in my experience, we often perform genetics before we do liver biopsy because it may help to really make a meaningful interpretation of the liver biopsy. Here on the right side, for example, you see the typical case of onion skin type sclerosing cholangitis. And I'm sure every pathologist in the world would make the diagnosis of small duct PSC. But this was a case of ABCB4 deficiency in an adult patient, also giving rise to the picture of sclerosing cholangitis. So without the genetic diagnosis, it would be impossible to make this diagnosis. And I think this is extremely important to consider in patients with small duct PSC lacking IBD. I really would warn or advise against making a diagnosis of small duct PSC in the absence of inflammatory bowel disease. In this mixed bag, a lot of these genetic variants, mainly ABCB4 mutations, are kind of hidden. So I really encourage everybody to perform a genetic analysis of the classic transporter variants B4, B11 before proceeding to a liver biopsy, because it also helps the pathologist to interpret the findings. So let's move to the next slide, please. Now this slide is highlighting, we always talk about the gut-liver axis and think that this is linked to the pathogenesis of PSC. There are, of course, many potential explanations, such as the leaky gut, microbiota, microbial products translocating to the liver and causing hepatobiliary inflammation, or T-cell homing from the inflamed gut to the liver. But at the end, we have to admit that the correlation between IBD activity and PSC activity actually is not that clear. I would say, submit that in the classic PSC patient being referred to the liver clinic, very often we make the diagnosis of IBD after diagnosing PSC, for example, in the index colonoscopy. And the impact of biologicals treating IBD on the disease course of PSC really has been very disappointing. And there's also no established role for vancomycins or other non-absorbable antibiotics modifying the gut microbiota that this really would alter the disease course of PSC. There are some preliminary data, but overall, the link between IBD activity and PSC activity is actually unclear despite this tight association. So this is still one of the mysteries, and also led to great disappointment when we tested IBD targeted drugs, that these really had very little impact to no impact on PSC activity. And this is also summarized in the next slide, taken from a very nice review from Tom Carlson, kind of showing the disconnect between the progression of the liver disease, which is the red upper course, and the IBD activity, which comes and goes, showing the orange course. Actually, it becomes more clear after a liver transplantation that actually the recurrence of PSC, which is observed in up to 30% of cases, has been linked to IBD activity. So let's move to the next slide and kind of interrogate this association between gut activity and PSC disease course. Actually, there's some data that colectomy prior to liver transplantation lowers the risk of recurrent PSC. It was very interesting for me also to see that in the big Swedish cohort, about 10% of PSC patients had a colectomy before making the diagnosis of PSC, which is a little bit unexpected. And also before liver transplantation, these cases appear to have a milder disease course of PSC. So in a way, there is some evidence that colectomy may protect against progression of PSC, although we are very hesitant of recommending colectomy as a treatment of PSC. We would do that, for example, if we have recurrent PSC after liver transplantation. We would typically discuss that after, the second listing for liver transplantation when the patients still have uncontrolled IBD activity. So in most cases, the indication for colectomy is actually the occurrence of dysplasia, high-grade dysplasia, or even colorectal neoplasia, which results in the indication for colectomy. Next slide, please. This is a very interesting study from Birmingham, actually showing that colectomy only protects when you perform an ileostoma. When you perform a pouch, actually the risk of pouchitis is aggravated by the presence of PSC. So many of the patients who undergo colectomy for PSC IBD and have a pouch actually develop pouchitis. And the presence of pouchitis shown here in the blue curve, in this Kaplan-Meier curve, actually has an even higher risk of PSC recurrence than active colitis. So this is something to keep in mind. It appears to be the common theme of intestinal inflammation driving the risk for recurrence. So this is something to keep in mind. So really, when performing colectomy in order to prevent recurrent PSC, one has to perform an ileostoma to get rid of this risk of pouchitis. Let's move to the next slide, which is a recent paper which appeared in ACHHEP, which actually showed that pre-transplant colectomy was not protective. So there's a lot of controversy. Is colectomy really protective or not? And actually in this study, it's interesting that recurrent cholangitis before liver transplantation appeared to be a risk factor for recurrent PSC. So it appears to be, the kind of primed inflammatory system, which together with increased IBD activity and multiple cellular rejection episodes is adding to the risk of recurrent PSC. Let's move to the next slide, please. So let's highlight or discuss a little bit the unmet medical need of liver transplantation. If you go to the next slide, you will see the statistics of the indications for liver transplantation in Europe. So despite being a rare disease, autoimmune mediated liver diseases, especially PSC, actually are the third most common cause to be listed for liver transplantations. This is something which is a little bit surprising, perhaps. So overall, PSC accounts for about 5 to 7% of liver transplants in the US. If you go to the next slide, you see the different statistics over time. The left curve actually is showing the number of transplants, for example, performed for PBC, the blue line, which leveled off over time, perhaps due to the introduction of urso, whereas the indications for PSC showing the red curve here on the left panel, this is the UK data, but also the blue curve, the UNOS data on the right side, you see that the increasing prevalence, which kind of has leveled off, but definitely surpassed PBC or autoimmune hepatitis as an indication for liver transplantation. When we go to the next slide, you see, for example, the Nordic liver transplant program. It's perhaps not that surprising that in Norway, where PSC is very prevalent, 15% of liver transplants are performed for PSC, with numbers further rising. But also in the UK, PSC is the leading transplant indication, surpassing even alcoholic liver disease or other indications. Especially when you consider regraft showing in this highlighted box, you can imagine that the burden of transplants being performed for PSC is significantly contributing to the burden of liver transplantation. And even in France, there's the prediction that PSC may be the leading indication in the next year. Although, quite honestly, I would doubt that. I think there are still alcoholic liver disease is probably the leading and remains the leading indication. I also found some data from South America. So if you go to the next slide, this is some data actually from Brazil. from 3 large transplant centers, showing that PSC was the 5th most common indication for liver transplantation, being about 5% of all liver transplant indication in adults. The survival rate is pretty good, but you see actually the box on the right side, despite having a very good long-term survival of patients, 80% for 5 years, the graft survival is a little bit lower, 70-75%, due to graft loss, mainly due to recurrent PSC in these 20-30% of cases. If we go to the next slide, please. This is listing the indications for liver transplantation according to the EASL clinical practice guidelines. And you already see that the classic indication of decompensated liver cirrhosis or development of hepatocellular carcinoma is not the only path towards liver transplantation in PSC. We also have recurrent bacterial cholangitis or severe pruritus or jaundice, which cannot be managed endoscopically, which is an indication for liver transplantation. For example, in Norway, about 70%, and also in our center, 70 up to 20% of cases, I would say, are transplanted for recurrent bacterial cholangitis. This varies greatly between different centers. For example, in the UK or especially in the US, this is actually discussed very controversially. In Central Europe, we even gave MELD exception points for the presence of cholangitis to allow listing of those patients who usually have a rather low MELD. And then we have high-grade biliary dysplasia, also very controversial. So some countries, such as Finland, for example, survey endoscopically, even invasively with ESCP for dysplasia and consider high-grade dysplasia as an indication for liver transplantation. However, 20 in some studies, up to 60% don't show any signs of dysplasia on the liver explant. So this is a little bit controversial. And also early stage perihilar cholangiocellular carcinoma. I think this only applies to highly selective cases within the Mayo criteria. Certain size criteria and also staging criteria must be met. Usually those cases are treated with neoadjuvant chemoradiation before liver transplantation. I would say access to these programs is very limited. In Europe, for example, this is only Berlin offering this indication. In the US, it's the Mayo Clinic. So let's go to the next slide, please. When we look at the real life data and the prognosis on PSC, the median survival is around 14 to 13 years, which is quite short, I would say, for persons being diagnosed with at the age of 20 to 40 with this disease. However, the survival may vary greatly. This is mainly reflecting data from the IPSC study group and also from the tertiary center in the Netherlands, which were mainly transplant centers. When this was extended, for example, to peripheral practice settings, the survival was lower, so was longer, around 20 years. So certainly you have a referral bias between transplant patients being referred to transplant centers or patients who can be managed outside a transplant center. Let's go to the next slide, please. I find the Amsterdam-Oxford model very useful to discuss the prognosis. This is actually an app, so you can access that via the internet and enter the standard criteria shown here on the left and really get a nice Kaplan-Meier curve. There are many, prognostic models, including also the Presto, the artificial intelligence model developed by the Mayo Clinic. But I find this Amsterdam-Oxford score very useful. Very often the patient already come with this curve, and you can easily discuss the prognosis and the need for liver transplantation in the next 5, 10, and 15 years. So in clinical practice, this is a really very useful tool for discussion with the patients. Let's move to the next slide and discuss malignancy. If we move to the next slide, summarizing the high risk of malignancy, I think it's important to keep in mind that nearly 50%, 44% of death in PSC are due to cancer. So it's mainly cholangiocellular, but also colorectal. and gallbladder cancer. Especially, it's important to keep in mind that cholangiocellular carcinoma, 50% of cases actually manifest within the first year of diagnosis. So for me, when I get a referral with PSC, I always have the question, is already cholangiocellular carcinoma on board? And when imaging is not really of high quality, I think one should have a low threshold for early recall after initial diagnosis and repeat imaging at the center. Very often, this already leads to suspicious strictures, which are then further worked up endoscopically and leads to the diagnosis of cholangiocellular carcinoma. The prevalence actually, this 1.5% prevalence leading to this high 15 to 20% lifetime prevalence of cholangiocellular carcinoma has been discussed controversially recently by a large Swedish study showing a rather low prevalence or incidence of 0.5% per year, even questioning the value of screening, which of course we perform in those patients. It's also important to keep in mind that the presence of IBD not only drives colorectal cancer risk, but even to a higher degree, cholangiocellular carcinoma risk. So patients who have both PSC and IBD a much higher cholangiocellular carcinoma risk than those without IBD, perhaps also explaining the favorable outcome of patients with absent IBD. So let's move to the next slide, summarizing the suggested algorithm for follow-up in PSC. So despite no hard data really firmly showing a survival benefit with our current screening strategies, this is what we perform in everyday clinical practice. Every 12 months, I think most centers would agree that patients should undergo MRCP and also ultrasound. In my opinion, ultrasound is very important for detecting gallbladder lesions, which may be missed by MRCP. Colonoscopy, yearly colonoscopy. It's important to keep in mind when the index colonoscopy, which has to be performed in every patient with a diagnosis of PSC, irrespective of symptoms, is unremarkable. It's important to have a recall colonoscopy in asymptomatic patients after 5 years, because PSC may develop over time IBD, and this may remain asymptomatic. And also elastography is a very important way of monitoring patient. Here in the right box, I highlighted the patients with significant risk, and one of the most important risk predictors in daily clinical practice is liver stiffness above 10 kilopascal, or an ELF test also above 10. So that's easy to keep in mind, 10 ELF or 10 FibroScan. Those are patients who have an increased risk to develop clinical events. And this was recently confirmed by the FICO study, which was presented at the EASL meeting, shown in the next slide, please. This is a slide which Olivier Chasselier was kind enough to share with me. And you see here on the Kaplan-Meier curve, the survival probability free of liver transplantation, or the probability of developing clinical events such as cancer or the need of liver transplantation. When you are below 9.5, you have a very good prognosis. Between 9.6 and 14, the curve starts to drop, and above 14, those are patients who are really at high risk to need a liver transplant over time. And this is nicely shown also in the next slide, please, showing in this right upper curve that the progression of fibrosis is not linear in PSC. It's really this F3 space around 10 kilopascal, where you have an exponential increase of disease progression. And those are patients who develop clinical events. This is also shown at the lower curve, showing that actually the F2, F3 space, this is where you progress to decompensation, where you develop cancer and fulfill listing criteria for liver transplantation. So FibroScan and progression of FibroScan values over time is a very useful way to monitor those patients, as in other liver diseases. And this has nicely been confirmed by the FICO study. So let's move to the next slide, please. and finish up by reviewing the therapeutic landscape in PSC. And if we go to the next slide, this is showing the three pillars of PSC therapy. This is on the one hand, URSO, having a little crack because of the negative outcome of the high-dose URSO study by Lindor in 2009. Then we have endoscopy, and we already talked a little bit about liver transplantation. So let's move to the next slide. What do the guidelines recommend? So there's no approved established medical treatment. However, URSO at medium doses between 15 and 20 milligram per kg can be given. So both EASL and AASLD guidelines are open to the use and no longer discourage generally the use of URSO. However, the use of high-dose URSO, above 28 milligram per kg is of course discouraged, has been shown to be harmful with more clinical events, development of esophageal varices, and also colorectal dysplasia. The use of corticosteroids outside overlap syndrome and the use of antibiotics outside antibiotic prophylaxis for ESCP or treatment of bacterial cholangitis is not recommended to treat PSC per se. So there is no evidence that patients benefit from immunosuppressants or biologics or that long-term antibiotics such as vancomycin would be beneficial. ESCP, the space for ESCP is mainly dilatation and ductal sampling of high-grade, or how we say now, relevant strictures to exclude malignancy. And there's some controversy whether to perform just balloon dilatation or also short-term stenting. Recent study from the DILI stent actually discouraged the implantation of short-term stents, although there are certain cases which still need a stent to keep the stricture open. And we've discussed the excellent outcome of liver transplantation despite the risk of recurrence. Let's move to the next slide, please. This slide is summarizing the emerging treatment options. So basically, we have showing in the bottom line the immune modulatory therapies, which all have been disappointing when it comes to treatment or improvement of cholestasis, maybe because we need earlier diagnosis before sclerosis, where immune intervention logically would be expected to intervene with the inflammation, but not when you already have fibrotic strictures. So maybe it was not such a surprise. I mean, although there's some data that tofacitinib actually may be beneficial, there's also an ongoing trial with upadacitinib with the JAK1 selective inhibitor in PSC. So we'll see. Of course, we continue to try all the new emerging immunomodulatory treatments which we use for IBD and test them for IBC and look for signals when we treat underlying IBD, whether that also would improve PSC, but there's no recommendation for PSC itself. The same applies to microbiota-based therapy. No evidence that antibiotics such as vancomycin or that FMT would be beneficial, although in preliminary studies there's an improvement of ALK phos signals. So I think this needs to be further explored by studies. And then we have the whole space of bile acid-based therapies or the PPARs, which also target bile acid homeostasis with URSO, NOR-URSO as a novel therapeutic approach. I will discuss that briefly, and also fibrates. So I should mention that the EASL clinical practice guidelines made a very firm recommendation for the use of bezafibrate to treat pruritus as a first-line agent in PSC. There's also some data that fibrates may be beneficial to treat the underlying cholestatic disease like we've seen in PBC, and studies are still ongoing. So let's move to the next slide, please. So this slide is summarizing the mechanism of action of NOR-URSO, or norocolic acid, how it is has been renamed now, in order to avoid the confusion with URSO, because it's behaving totally different from URSO. Despite this slight chemical difference, it's a side chain shortened derivative of URSO lacking a methyl group at the side chain. And this makes it resistant to conjugation. And as a result of this resistant to conjugation, NOR-URSO or norocolic acid is undergoing colohepatic shunting between the bile duct and the hepatocyte. And this generates a bicarbonate-rich cholerasis. So bicarbonate is very important to flush the bile duct and counteract bile acid toxicity in addition to the formation of mixed micelles. So one very important aspect of the mode of action. In addition, urocolic acid is targeted to the inflamed bile duct and also has anti-inflammatory and even immunomodulatory action. And you see here in the right histological images that basically in this mouse model of sclerosing cholangitis, the MDR2 knockout mouse, you get total reversal of the phenotype and total normalization of the biliary system, which led to the development of urocolic acid for the treatment of PSC. When we move to the next slide, this slide is summarizing some of our recent data showing that urocolic acid or NOR-UDCA also modulates immunometabolism in CD8 and CD4 T cells. So it's a kind of immunometabolic modulator. At the end, it comes down to fine-tuning of mTOR signaling, which especially in the space, the CD4 space, results in a redifferentiation of Th17 cells into regulatory T cells and an anti-inflammatory milieu. This could be very important when we move to the next slide, when you consider the role of this Th17 regulatory T cell imbalance, which has been shown to play a key role both in the pathogenesis of IBD and sclerosing cholangitis. So when you have too little regulatory T cells suppressing inflammation and too much Th17 effector cells causing the immune-mediated damage and inflammation, then this causes hepatobiliary inflammation and colitis. And the next slide will show you that intriguingly also in our preclinical models, for example, a CD4 T cell transfer colitis model, urocolic acid was able to prevent colitis. So this, of course, begs for the question, could this also be relevant in patients? I think this is something which needs to be explored in the future and could come down to this immunomodulatory action of urocolic acid. Since it's an unconjugated bile acid, it does not require any specific transport systems to get access to the T cells and have these immunometabolic modulatory functions. Let's move to the next slide. So these very promising preclinical data have led to a phase 2 study, which you're probably aware of, with a dose-dependent reduction of cholestatic liver enzymes, alkaline phosphatase, gamma-GT over 12 weeks. And based on this encouraging study, a phase 3 study, which is conducted in Europe with more than 300 patients, has meanwhile been fully recruited, and actually the last patient out will be in July. So we expect the data of this trial by the end of this year. So this will be certainly exciting to see whether these very interesting preclinical findings and encouraging phase 2 studies also hold up for in a phase 3 study, which has a combined biochemical and histological outcome. If that study is positive, this would be the first approved therapy for PSC. So certainly very exciting times and encouraging times for people with PSC at the moment. Next slide, please. The next slide is summarizing the top data of the recent phase 2 studies. Also for the FXR ligands for urocolic acid, there was a positive phase 2 study. One problem, of course, also there was pruritus, although the dose used there was only half of the PBC dose. The study with Xylofex, a non-steroidal FXR ligand, unfortunately was negative, so the phase 3 study was prematurely stopped for futility reasons. I've presented that data last year at EASL in Vienna. NOR-UDCA, the phase 3 study is still ongoing, and we will soon have the results. And there are also data with aldafermin, which interestingly did not improve cholestasis, but improved fibrosis markers such as ALF test and PRO-C3. So we'll see where that goes. In my understanding, both aldafermin and also obeticholic acid are planned to be developed and perhaps tested in phase 3 in the future. And unfortunately, the data with zenicriviroc, with the CCR2, CCR5 inhibitor, and simtuzumab with the Loxel inhibitor, the antifibrotic drug, were negative. The next slide is summarizing the phase 3 data. Yeah, I mentioned that the Xylofex study. Actually, this was so far the largest study conducted in PSC so far, with more than 400 patients. And unfortunately, the histological endpoint, which in this study was a pure histological endpoint improvement in fibrosis according to the Ludwig stage, there was no difference between the Xylofex and placebo group, although there are some signals when it comes to improvement of fibrosis. So deterioration of fibrosis was not different. Improvement of fibrosis in F3 fibrosis. In sub-analysis, you'll hopefully see the full paper in the near future. There was a potentially positive signal, but overall the study, unfortunately, was negative. And the next slide is summarizing where we stand at the moment with emerging treatment options. So in addition to URSO homologs such as no-URSO, there's also a berberin URSO derivative, which was positive in phase 2. There are the FXR agonists and the FGF19 analogs with OCA and probably the aldafermin being developed further after phase 2. There are the PPAR agonists in addition to the fibrates, of course. There's also the better fibrate study ongoing in France at the moment. So they basically repeat of what they have done in PBC with elafibranor, with the alpha gamma ligand, the alpha delta ligand. There is a phase 2 study ongoing, and probably also seladelpar, the pure delta ligand. I could imagine that there will be a phase 2 study in PBC as well. And then on the left, we have the IBAT inhibitors, which have been very promising in the PFIC space for the treatment of pruritus. And also we and others have shown encouraging preclinical data, although in studies there was no biochemical signal in terms of improvement of cholestasis. But we'll see, at least for the management of pruritus, I think this is an interesting approach. And then on the right hand, of course, we still have biological approaches, especially the bexotegrast, which is an inhibitor, an integrin inhibitor, also interfering with fibrosis, and TGF-beta signaling, where we had some encouraging phase 2 data, which likely will progress to phase 3 as well. So with this, I come to my concluding and last slides. I think, you know, there are many unresolved clinical challenges in PSC. It's a heterogeneous condition. It's certainly more than one disease. And I always like the comparison of Michael Manns, who says PSC is the liver cirrhosis of the bile duct. And I think by that he not only means the end stage of it, but also as we classified liver cirrhosis before we discovered viral hepatitis, autoimmune hepatitis, hepatitis B, C, D. I think this is where we are with PSC at the moment. In our understanding, where we were with parenchymal liver disease, perhaps in the 60s and 70s, and hopefully we'll make some progress there. It remains a black box. There are many conceptually appealing therapeutic targets. I think in the near future, those bile acid targets, norocolic acid, the PPARs, probably will lead to the first breakthrough. Microbiota is interesting, but I think still a little bit far away at the horizon, what that really means for the pathogenesis. And immunomodulatory drugs, I think we have to diagnose the disease earlier. At the moment, I think we are much too late. It's like, you know, diagnosing parenchymal liver disease, hepatitis at the stage of liver cirrhosis only, and then think about causal treatment. I think we are far too late, and likely a complex disease such as PSC will require combination therapy. With this, I want to thank for your attention, and I hope we still have some time for questions. Thank you very much.
Bueno, muchas gracias, doctor Trauner, por esta estupenda presentación que nos aclara un montón de dudas que siempre uno tiene en estos pacientes que son extraordinariamente desafiantes. Acá en Chile tenemos la suerte de tener menos colangitis esclerosante primaria que otras enfermedades autoinmunes, pero sin duda cada vez que se nos presentan estos pacientes son muy, muy desafiantes. Quisiera abrir la posibilidad de que el público preguntara. Estamos
I have a
abiertos
question.
a preguntas.
So I add to the words of Fernando, thanking you, Michael, because your talk was really fantastic. I mean, I learned a lot. So thank you.
That means a lot.
Yeah, and I have a question for you, a clinical question about the when you face sclerosing cholangitis and you have elevated IgG, don't have IBD, um, and you just tempted to use steroids. So which is your approach in that?
Right. Yeah. Quite honestly, if I suspect overlap with autoimmune hepatitis and, elevated IgG and perhaps also elevated ALT, which does not respond to URSO, would lead to the question, is there overlap syndrome? So the next step would be perform a liver biopsy. And quite honestly, when I see inflammation on the liver biopsy, I treat inflammation on the liver biopsy, no matter what you call it. Yeah, I would be very liberal. Those are patients where, adding, especially the data also from Hamburg, if the patients are not cirrhotic, maybe budesonide or, a short steroid pulse, not too high, and then switching to azathioprine, I think is justified. My message is if you see inflammation, treat inflammation, don't ignore it.
Yeah, and the other overlap that is complicated is with the IgG4.
Sure. Yeah.
How
That's
is your
tricky.
approach?
Yeah. That's very tricky. I mean, it comes to cutoffs. And then, what is the cutoff to lead to a firm diagnosis of IgG4 related disease? I mean, above threefold elevated, I would be more confident. Below that, I mean, I do the IgG1, IgG4 ratio. I also have to look up, the algorithm, which one is kind of supporting the diagnosis. I mean, there are also some centers have access to look at clonal expansion of IgG4 by PCR. At the end, it comes to clinical judgment. If there is significant elevation of IgG4, I would have also considered the diagnosis of IgG4 related disease and also try a steroid pulse. If I always would try anticholestatic treatment such as URSO first. If the patients don't improve their cholestasis, and sometimes the ALT increase at least is driven by cholestasis, not so much the IgG4, IgG increase, I would say. Yeah.
We have a question here. I don't know, Fernando, if you want to translate that. Is from Professor Lazarte.
No veo la pregunta. Dila tú.
Yeah, a colleague asked about if you can get deeper in which are the factors that makes the disease more aggressive and more rapid progression, including probably genetic factors. We, of course, are not Nordics, and we see actually very few patients of PSC here in Chile. It's a rare disease, and probably that relates to genetic background. But so your comments on that.
Right. I mean, certainly, quite honestly, I think overall the aggressiveness of IBD is also determining the disease course. Although the fluctuations do not always correlate with the immediate deterioration of PSC. So, for example, we follow a strategy that patients with long-standing severe colitis, we put them into the scanner irrespective of the alkaline phosphatase. I mean, and then we often see early cholangiographic changes or already firm cholangiographic changes of PSC. You're probably aware of the Norwegian studies. They found a threefold higher prevalence of PSC with this approach because alkaline phosphatase can be normal in PSC. The question is, why do we do this? Isn't it just causing, harmful thoughts to patients for a disease where we have no treatment? My answer to that would be, I think it reclassifies the patients in terms of cancer risk. A patient with PSC IBD has a much higher risk of colorectal cancer, apart from the cholangiocellular carcinoma risk. And I would enter those patients in screening programs, yearly colonoscopy, which you would not necessarily perform in controlled IBD, and of course would start patients with URSA. So presence of IBD, and also patients who, at the end, it's also the cholangiographic appearance. Patients who have this extensive involvement of the intrahepatic and perhaps also the extrahepatic tree. Those are patients who progress. Patients who just have one or two little strictures, those are patients who usually do fine. It's at the end, it's the degree of the involvement of the biliary tree. And of course, I think at the end, always the monitoring the fibroscan over time will show you. If the fibroscan shifts over time, those are the patients who are shifting in this curve. And pay attention when patients get closer to this 10 kilopascal space. Of course, one has to be very careful. Patients also with jaundice or intermittent, colangitis or dominant strictures also will have an increase in the fibroscan. This is not always fibrosis, as we know.
Thank you. I guess we have a few time for questions, so you can go.
Okay, I would like to ask Dr. Trauner about the risk of cholangiocarcinoma, because we know we always are thinking in when the patient could have cholangiocarcinoma. Would you explain us a little more about when you suspect, and how and what do you say to your cholangiographic? What kind of sample would we need to do a diagnosis?
Yeah, every dominant stricture is a cholangiocellular carcinoma until proven otherwise. I think it's always important to suspect cholangiocellular carcinoma and perform biopsies. If you can reach the stenosis cholangioscopically, I think the cholangioscopy, although it's often technically difficult in PSC, is giving you more control of the biopsy than with ERC, and also visually you sometimes already see the abnormal tumor vessels and the papillomatous formations. So I think biopsy, you also can make the diagnosis with cytology or FISH. We don't have FISH, many centers in the US have. I think at the end, the pathologists are more confident with the histological than cytological diagnosis. And also, we immediately put, for example, the sample. We no longer do smears. We put everything into formaldehyde and let the pathologist spin down the samples and do the cytology. So in former times, we were doing smears directly in the endoscopy unit, for example. This also increased the yield of the cytological diagnosis from the pathology colleagues.
Mm-hmm.
Yeah, and at the end, always be very suspicious. I think one should be most alarmed when you see the PSC patients first. This is a little bit counterintuitive because we always think it's something which develops over time. I think many, like when I see a PSC patients, the concern is always, is there already PSC on board, especially when there's a dominant stricture and they see the patient for the first time. I would repeat the cholangiography and be very liberal in performing an ERC to make the diagnostic workup of the stricture.
Thank you.
If I may, I will ask, there is a question here. It says that you mentioned genetic testing. Is it possible to send samples for genetic testing to your center? Do you have, do you recommend any place?
Yes, actually, we perform it. We in the meantime, we are no longer allowed to do it ourselves. We have a very strict EU regulation, and our hospital likes to centralize everything. So it's sent to our Department of Human Genetics. Yeah. So I would advise to get in contact with your genetics institute at the university, and that they establish that, especially for B4. It's very complex because they have to whole genome sequencing, exome sequencing, and at the end, the interpretation also is changing. So you need somebody who is monitoring the result and will inform the patient later when, for example, the assignment of a variant changes. Also from an ethical and legal perspective, I think there is no space for homemade, do-it-yourself in your lab space, like for hemochromatosis. It's not just a PCR, you do yourself. it's more complex, also counseling the patients. I think it's worthwhile to have one national center. Maybe if you don't have such a center in Chile, probably Santiago de Chile would be the right space to establish that. I think it's worthwhile. And talking about genetics, to very much of my disappointment, being interested in PNPLA3, there's no role of PNPLA3 in sclerosing cholangitis, although it's highly expressed in cholangiocytes. I have no explanation for that.
Yeah, here we have a very high prevalence of that, at least
Yeah.
for the risk allele for MASH, and
Right.
we have access some commercial companies that do a panel of cholestasis mutations. In Chile, for the audience, there is access to Invitae and Blueprints Genetics that they sell the test. You trust in them? I mean, they I don't think that they do whole genome analysis. Rather, they do the most common mutations, but
Right.
they may be useful anyway.
I think it's a useful first step. They're more set up for the pediatric, the severe manifestations. It's like in Wilson's disease that in the adult space, I'm always surprised. Sometimes you have the same mutation, which is causing different manifestations in family. One woman having intrahepatic cholestasis of pregnancy, and her brother has liver cirrhosis and is ending up in the transplant list. There's more variability in those milder variants, probably some exogenous factors which we do not fully understand. Yeah.
You are right. Okay, I think we are reaching the end. It's almost 9 o'clock. Again, Michael, we are deeply thankful for your presentation, your generosity to share your knowledge, and I think this has been a great meeting. So thank you, and we leave you, and we see soon. We see each other soon. I hope.
Thank you.
I hope
Thank
so
you very
too, and
much.
thank you much. Thank you much for the invitation and also talking to what I perceive very experienced audience. Thank you very much.
Okay, bye bye.
Igual. Bye.
Muchas gracias a
Thank you.
todos por
Muchas
la reunión.
gracias.
Hasta
See you.
pronto.
Bye.
Muy bien, estamos nosotros aquí. Salió bien al final. Casi se nos